Welcome back, our fans. Basic injection techniques. Not only can the injection of local anesthetics produce fear and pain, it is also a factor in the occurrence of emergency medical situations. Most of these emergency situations were directly related to increased stress associated with receipt of the anesthetic, the injection, and not to the drug being used. More than half of these emergencies, 15,407, were vasodepressor syncope, common faint, most of which occurred during or immediately after administration of the local anesthetic. A traumatic injection has two components, a technical aspect and a communicative aspect. Step 1: Use a sterilized sharp needle. Stainless steel disposable needles currently used in dentistry are sharp and rarely produce any pain on insertion or withdrawal. However, because these needles are machine manufactured, occasionally, rarely, a fishhook type barb may appear on the tip. This results in a traumatic insertion of the needle followed by painful withdrawal as the barb tears the anesthetized tissue. Disposable needles are sharp on first insertion. However, with each succeeding penetration, their sharpness diminishes. By the third or fourth penetration, the operator can feel an increase in tissue resistance to needle penetration. Clinically, this is evidenced by increased pain on penetration and increased post-anesthetic tissue discomfort. Therefore, it is recommended that stainless steel disposable needles be changed after every 3 or 4 tissue penetrations. Also, the needle gauge could produce pain on injection. Needles of 23 gauge and larger are associated with increased pain on initial insertion. Diamond, Step 2. Check the flow of local anesthetic solution. After the cartridge is properly loaded into the syringe, only few drops of the solution should be expelled from the needle to determine whether a free flow of solution occurs. Diamond, Step 3. Determine whether to warm the anesthetic cartridge or syringe. If the cartridge is stored at room temperature, approximately 22 C, 72 F, there is no reason for a local anesthetic cartridge to be warmed before its injection into soft tissue. Cartridges stored in refrigerators or other cool areas should be brought to room temperature before use. It is recommended that both the local anesthetic cartridge and the metal syringe be as close to room temperature as possible, preferably without the use of any mechanical devices to achieve these temperatures. Holding the loaded metal syringe in the palm of one's hand for half a minute before injection warms the metal. Diamond, Step 4. Position the patient. Any patient receiving local anesthetic injections should be in a physiologically sound position before and during the injection. Vasodepressor syncope, common faint, the most commonly seen medical emergency in dentistry. Most often occurs before, during, and, on occasion, immediately after local anesthetic administration. Decreased cerebral blood flow is evidenced by the appearance of signs and symptoms of vasodepressor syncope, e.g., lightheadedness, dizziness, tachycardia, palpitations. If this situation continues, cerebral blood flow declines still further, and consciousness is lost. To prevent this, it is recommended that during local anesthetic administration, the patient should be placed in a supine position, head and heart parallel to the floor, with the feet elevated slightly. Diamond, Step 5. Dry the tissue. A 2x2-inch gauze should be used to dry the tissue in and around the site of needle penetration and to remove any gross debris. Diamond, Step 6. Apply topical antiseptic, optional. After the tissues are dried, a suitable topical antiseptic should be applied at the site of injection. This further decreases the risk of introducing septic materials into the soft tissues, producing inflammation or infection. Antiseptics include betadine, povidone iodine, and merthiolate. Thimerosal. Diamond, Step 7a. Apply topical anesthetic. A topical anesthetic is applied after the topical antiseptic. It should be applied only at the site of needle penetration. All too often, excessive amounts of topical anesthetic are used on large areas of soft tissue, producing undesirably wide areas of anesthesia, for example, soft palate, pharynx, and unpleasant taste. Topical anesthetics, such as lidocaine, rapid absorption into the cardiovascular system, CVS, leading to higher local anesthetic blood levels, which increase the risk of overdose. Only a small quantity of topical anesthetic should be placed on the cotton applicator stick and applied directly at the injection site. The topical anesthetic should remain in contact with the tissue for 2 minutes to ensure effectiveness. Diamond, Step 7b. Communicate with the patient. During the application of topical anesthetic, it is desirable for the operator to speak to the patient about the reasons for its use. Note that the words injection, shot, pain, and hurt are not used. These words have a negative connotation. They tend to increase a patient's fears. Diamond, Step 8. Establish a firm hand rest. It is essential to maintain complete control over anesthetic syringe at all time. A firm hand rest is necessary. The types of hand rest vary according to the practitioner's likes, dislikes, and physical abilities. Persons with long fingers can use finger rests on the patient's face for many injections. Those with shorter fingers may need elbow rests. 2 techniques to be avoided are: 1. Using no syringe stabilization of any kind. 2. Placing the arm holding the syringe directly onto the patient's arm or shoulder, both resulting in inadvertent needle movement and injury. Diamond, Step 9. Make the tissue taut. The tissues at the site of needle penetration should be stretched before insertion of the needle, except in palate. Stretching of the tissues permits the sharp stainless steel needle to cut through the mucous membrane with minimal resistance. Diamond, Step 10. Keep the syringe out of the patient's line of sight. Assistant should pass the syringe to the administrator out of the patient's line of sight, either behind the patient's head or across and in front of the patient. Diamond, Step 11a. Insert the needle into the mucosa. As a general rule, the bevel of the needle should be oriented toward bone, then inserted gently into the tissue at injection site to the depth of its bevel. Diamond, Step 11b. Watch and communicate with the patient. The patient's face should be observed for evidence of discomfort during needle penetration. Signs such as furrowing of the brow or forehead and blinking of the eyes may indicate discomfort. Diamond, Step 12. Inject several drops of local anesthetic solution. Diamond, Step 13. Slowly advance the needle toward the target. Steps 12 and 13 are carried out together. The soft tissue in front of the needle may be anesthetized with a few drops of local anesthetic solution. After 2 or 3 seconds are allowed for anesthesia to develop, the needle should be advanced into this area and a little more anesthesia deposited. The needle should then be advanced again. These procedures may be repeated until the needle reaches the desired target area. Use of a buffered local anesthetic will increase patient comfort during injection as a result of 1. The increased pH of the anesthetic solution, 7.35 to 7.5. 2. The presence of CO2 in the buffered solution. CO2 possesses anesthetic properties in an injection such as the inferior alveolar nerve block, for which the average depth of needle insertion is 20 to 25 millimeters, not more than 1/8 of a cartridge of local anesthetic should be deposited as the soft tissues are penetrated. However, aspiration should always be carried out before any significant volume of solution is deposited. Diamond, Step 14. Deposit several drops of local anesthetic before Touching the periosteum. In techniques of regional block anesthesia, for example, inferior alveolar, Gauss-Gates mandibular, and infraorbital nerve blocks, in which the needle touches or comes close to the periosteum, several drops of solution should be deposited just before contact. Thanks for watching. Support us by likes and subscribes.